Dear friends, in this video, I'm going to talk about the critical care bundles. As it is already well known that adoption of certain bundles improves the quality of care in critical care medicine, not only in terms of reducing the mortality and morbidity, but also in reducing the length of hospital stay and the length of ICU stay. And therefore, this care bundles have a profound influence as far as the cost component is concerned. So, what are these care bundles? Care bundles are nothing but a group of 3 to 5 evidence-based interventions related to a particular condition or disease or an event in patient care that, when executed together, result in a better outcome than if they're implemented individually. Now, very simply, we can understand by citing a simple example, like a team event where there may not be too many star players, but if each of the player complements the other in a definite way, then the performance of the team becomes better. Then each of the scoring runs are performing without much of a synchrony or synergism. So each intervention is widely accepted as a good practice and it is widely applicable. They should be adhered to every patient in the ICU for most of the time. They can be used to measure evidence-based practice and can be audited at every step. And the audit, which is for those care bundles, is focused more on the organizational aspects of performing intervention and not on the technical aspects. Let us start with the case. A 40-year-old male complains of fever, cough with expectoration and respiratory difficulty for 2 days. The blood pressure is 90/50, heart rate is 120, respiratory rate is 30, breathing is shallow, saturation is 80%, temperature is 101 degree Fahrenheit. The chest shows bilateral reduced air entry. The capillary refill time is 3 seconds. The USG abdomen shows IVC with 1.2 centimeter diameter and a collapsibility of 70%. The lung ultrasound shows consolidation with B profile, bilateral consolidation on the right side. Abdomen is normal. The CNS examination shows mild delirium, although the GCS appears to be normal. Now, which care bundle is important for this patient? So as you can understand that this patient is in sepsis or severe sepsis. So therefore, the sepsis bundles are of immense importance in the quality outcome of these patients. If we go back to 2005, we found that in the sepsis bundles of the Surviving Sepsis campaign, there were two bundles, one 6-hour resuscitation bundle and another 24-hour resuscitation bundle. Subsequently, in 2013, it became 3-hour bundle and 6-hour bundle, and 24-hour bundle was no longer recommended because the importance of time assumed more and more importance in this intervening period. Finally, when we look into the 2018 sepsis bundle, we find that there is 1-hour bundle, which consists of 5 interventions. 1, measure serum lactate, remeasure if the initial value is more than 2 millimoles per liter, obtain blood cultures prior to administering antibiotics. 3, administer broad spectrum antibiotics. 4, begin rapid crystalloid infusion at the rate of 30 ml per kg. And 5, apply vasopressors if hypotension remains even after fluid resuscitation to maintain a MAP of equal to or more than 65 millimeter of mercury. Now we call them bundles because each of them can be audited, evaluated, and if you just stick into one of them, we can probably get an outcome. But if we can collectively implement them, we get a much better outcome. So following this 2018 Surviving Sepsis campaign guideline revisions, the 3-hour and 6-hour bundles were combined into a single 1-hour bundle of 5 elements. And that's what is important in the context of this patient. If we look into the grade of recommendation and the level of evidence that exists today for each of these components, if we go to the measurement of lactate, we find that the grade of accommodation is weak because the quality of evidence is low. In obtaining blood cultures prior to antibiotics, is grade of recommendation is a best practice statement. Whereas for administration of broad spectrum antibiotics, rapid administration of 30 mils per kg of crystalloids for hypotension or lactate more than 4 millimoles per liter has a strong recommendation, although the low quality of evidence. And application of vasopressors to maintain the mean arterial pressure of more than equal to 65 millimeter of mercury during or after fluid resuscitation has a strong recommendation, although moderate quality of evidence. So automatically question comes that if the recommendation is not so strong in all of these individuals and the quality of evidence is either low or moderate, then why do we include this as bundles? The answer is very simple. The changes are based on the concept that sepsis is a medical emergency requiring immediate and timely intervention to improve survival, not only at the time of presentation, which we technically refer as time zero, but also during the subsequent hours of entry into the medical system, that is during the processes of ongoing evaluation and intervention. So this is the reason why, despite the recommendation not being strong for all the individual components, we have included them in the bundles. However, some dispute still exists because certain definitions are not identified because it is unclear which patients require rapid assessment at time zero, but probably in time to come, we can have more clarity over this as also. If we go into the published literature, we find that implementing sepsis bundles results in the decrease in the mortality and leads to better outcomes in septic shock patients. And this benefits mainly depend on compliance with the sepsis bundles and highlights the importance of dedicated educational programs at the grassroots level or the middle level to, to instill confidence into the caregivers about the necessity and importance of these bundles. If we look into the other paper, also we find that adherence with severe sepsis or septic shock management bundles can improve survival. And among all, this bundle adherence seems to be most beneficial for patients with pneumonia. Coming to the next case, a 50-year-old male with chest wall injury, fractured ribs with pneumothorax and flail chest for a day, who is hemodynamically stable otherwise, is brought, and patient is treated conservatively with a left-sided chest tube to drain the pneumothorax. Initially, the patient is on high flow nasal cannula at 50 liters per minute. Subsequently, was taken on mechanical ventilation for dip in the oxygen saturation. The patient is a chronic smoker with a history of pulmonary coughs, for which was treated 10 years ago. Which care bundle is important for this patient? As it is very clear from this that such patients are very prone to develop ventilator-associated pneumonia. And if we make effort to increase the bundle compliance, education, and documentation of a VAP, then that can reduce mortality, improve outcome. So the use of ventilator-associated pneumonia bundles leads to an increased vigilance in the care of the ventilated trauma patients and reduction in the VAP rates. And as has been pointed out in this study, these VAP bundles consists of 5 evidence-based practices, including subglottic suctioning, oral care, endotracheal tube rotation, although this is not a part of a bundle anymore, nursing documentation, and GI prophylaxis. But even with this, the VAP rate pre and post implementation of VAP bundle was found to be reduced by nearly 8%, which is very significant in critical care practice. So today, what are the elements of VAP bundle that we have incorporated or substituted from the many, and what is their importance? One, importance of subglottic suction tubes, because secretions that pull above the endotracheal tube but below the vocal cords are potential source of pathogens that can result in VAP. And the conventional suction methods cannot access this area. So the endotracheal tubes that have a designated suction catheter for this space allows this pool to be drained. So this is a well accepted and adjudged component which is a part of the VAP bundle. And whether the patient is on an endotracheal tube or a tracheostomy tube, subglottic suction should be used in patients who are anticipated to be mechanically ventilated for over 72 hours. The second component of the VAP bundle is the measurement of the cuff pressures. We know that microaspiration can be reduced by maintaining an endotracheal tube cuff pressure between 20 to 30 centimeter of water, and individual assessment is required because patient's clinical condition and ventilation may require higher pressures, and at times the cuff pressure is likely to increase, and the rationale for decision must be documented and the position should be reviewed daily. We neither can give too much of pressure because that can cause ischemia. If we get too less pressure, that can cause aspiration. So mechanically ventilated patients should have cuff pressure maintained between 20 to 30 centimeter of water, optimally around 25 centimeter of water. The third important element in VAP bundle is daily sedation interruption and assessment of the readiness to extubate. We know that the continuous sedation can lead to accumulation of sedatives. It can cause over-sedation and an increased duration of mechanical ventilation. If there is increased duration of mechanical ventilation, there will be obviously increased duration of intubation. And therefore, these patients get predisposed to VAP, which reduces the which increases the mortality and the morbidity overall, and also increases substantially the risk of developing VAP. So strategies used successfully to reduce the duration of mechanical ventilation are daily sedation interruption and spontaneous breathing trial. Therefore, targeting sedation of mechanically ventilated patients can preserve or reinstate spontaneous breathing much earlier and in a better way to facilitate liberation from ventilation and reduce the risk of VAP. The next important element of VAP bundle is semi-recumbent position. We know that aspiration of oropharyngeal or gastric contents is implicated in the pathogenesis of VAP, and nursing the patient in mechanically ventilated patient in a semi-recumbent position can prevent aspiration of gastric content, while elevating the bed to 45 degrees has been shown to reduce the VAP. It may not be always achievable, but even if it's somewhere between 30 to 45 degrees centigrade, it can be useful in reducing the risk of VAP. So patients should be nursed in a semi-recumbent position around 30 degree to 45 degree unless contraindicated otherwise. Avoidance of scheduled ventilator circuit changes. We know that humidified gases condense in the ventilatory circuit and are at risk of becoming contaminated. Evidence suggests that frequent circuit changes are associated with increased incidence of VAP due to excessive manipulation of the ventilator circuit, which causes contaminated secretions to enter the bronchial tree via the by the ETT lumen. So changing the ventilator circuit should occur only when clinically indicated, such as there is a visible soiling or when the manufacturer's recommendations demand so, not always, not as a routine procedure. Besides this, there are two other elements which are also useful, although there is no very strong evidence is still not there, but prevention of stress ulcer must be weighed against the risk of increase in VAP. There is insufficient evidence to give a clear recommendation on the use of stress ulcer prophylaxis and the potential protective benefits, but there is sufficient evidence also to prove that these are useful, although that usefulness is not measurable in absolute terms always, but it is useful. And oral hygiene also plays an important role in ventilated patients in order to remove dental plaque. So stress ulcer prophylaxis used judiciously and in patients considered to be at high risk of upper bleeding, combined with regular oral hygiene should be maintained. And this also forms part of the VAP bundle because oral care should be assessed and delivered according to the risk of the patient. So if we individually try to look at these and try to see what is the effect of these processes of care on time to extubation alive, ventilator mortality, time to discharge, hospital discharge alive, and the hospital mortality, we can clearly see that the benefits are statistically visible, and not just statistically, even clinically they are visible. Over half the cases of VAB may be preventable with evidence-based strategies and have an impact on the mortality. Coming to case 3, a 40-year-old male post-cardiac surgery patient has CVP and arterial catheter for the past 2 days. Patient is hemodynamically unstable on vasopressors and inotropes. Patient has been weaned and extubated from mechanical ventilation, but could not be weaned from these vasopressors and inotropes. The post-operative echo shows a ejection fraction of 20 to 25% along with global hypokinesia. Now, which care bundle is important for this patient? We can well see that this patient is on CVP and arterial catheters, which are likely to remain considering the hemodynamic instability. And therefore, we have to be careful to prevent CLABSI or CRABSI in this patient. There is a subtle difference between CLABSI, which is central line associated bloodstream infection, and CRABSI, which is a catheter-related bloodstream infection, because catheter-related bloodstream infection requires a pathological diagnosis through positive blood cultures, whereas central line associated bloodstream infection is a bloodstream infection in a patient with central line in situ or removed in the last 48 hours with no other obvious cause of infection, which means the positive blood culture is not mandatory. So, since positive blood culture is very difficult to decipher at times, the CRBSI causes a huge burden, and the CLABSI is only the tip of the iceberg. As you can see that CRBSI can be caused by peaks, midlines, dialysis, excess, so many causes where positive blood culture may not get revealed. Therefore, CLABSI was developed to serve as a surrogate measure for the CRABSI or CRBSI, although the causes of CRABSI are much more and its impact on the healthcare is much more immense than CLABSI. If you look into the studies, there are so many studies performed, and this meta-analysis has already incorporated 57 studies to show that implementation of central line insertion and maintenance bundles reduces the incidence of CLABSI in ICUs and non-ICU settings. So when we like to look into this insertion bundle and maintenance bundle, what are these? So hand hygiene, it is a component which is common in both insertion bundle and maintenance bundle. Application of maximum sterile barrier precautions on insertion as well as during maintenance is a common approach or a common practice in both the bundles, performing all supplies for procedure at the bedside, disinfecting skin with chlorhexidine, using an insertion checklist, empowering staff to stop non-emergent procedure if breaches in aseptic technique are observed. All this form part of the insertion bundle. Whereas in addition to the first two, daily assessment of the catheter need, reviewing the dressing integrity and cleanliness, using closed system for infusion, blood sampling and medication administration, assemble and connect infusion tubing through aseptic technique, using maintenance checklist and empowering staff to stop non-emergent procedure if breaches are observed are all part of the maintenance bundle. Coming to the fourth case, a 70-year-old female undergoes pelvic surgery with radiotherapy for CS cervix. Patient is catheterized due to bladder involvement. Patient experiences fever with chills, lower abdominal pain after 4 days. Response to aminoglycosides plus quinolones. The catheter is changed. Which care bundle is important for this patient? As we know that COTI is a very frequent association, particularly in patients who have undergone surgery in the lower pelvis. And according to CDC, the definition of COTI should satisfy the patients must meet all the 3 criteria. And this includes indwelling urinary catheter in place for more than 2 days on the day of infection. At least one of the following 6 components, that is fever more than 38, suprapubic tenderness on pain in the costovertebral angle, dysuria, urinary frequency and urinary urgency, and 3, positive urinary culture with 2 or fewer species of microorganism grown, with at least one being a bacterium with more than 10 to the power 5 CFU per mils. So this satisfies us and our case, and we have to think that doesn't satisfy because we don't have a positive urine culture. But if it satisfies, it is COTI. If it doesn't satisfy, the patient may have a risk of COTI. And there are certain concordant signs and symptoms of COTI, and there are certain discordant signs and symptoms of COTI. So concordant signs takes us more towards COTI. Discordant signs takes us away from the COTI, but both are useful because one increases the positive likelihood of having COTI and other reduces the negative likelihood of COTI by chance. So if you look into this fever, delirium, rigors, flank pain, hematuria, pelvic discomfort, urgency, dysuria, suprapubic pain, these are all concordant signs and symptoms of COTI, whereas pyuria, foul smelling urine, change in urine color, resistant organism in the urine, weakness, prior UTI diagnosis, these are all discordant signs and symptoms of COTI. We have to adopt a 4-step care bundle like aseptic insertion, proper maintenance and dependent drainage, condom catheterization in appropriate patients, and catheter required where daily assessment of the need for catheter as a 4-step care bundle to reduce the COTI. So to keep things simple, keep it out because only insert catheter if indicated, keep it clean, use hand hygiene before touching, meatal and pericare twice a day with documentation, keep it secure to reduce catheter movement into and out of urethra. Every time it moves into or and out, it increases the risk of infection. Keep it closed by using a closed system. Keep it low by having a drainage bag and tubing below the level of the bladder. Also avoid loops or kinks and keep it clear. Send urine culture when there is a clear indication of symptoms. So to have no COTI, we can remember this mnemonic, no COTI, where N stands for need for catheter assist, O for obtained patient consent and offer patient education, C for competency, that is clinicians who insert catheters must have demonstrated competency, asepsis, because maintaining asepsis during insertion or while catheter is in place, unobstructed flow, that is no kinks or loops, catheter secured back below the bladder level, timely catheter removal and documentation, which can be nurse initiated, and infection risk, collect urine specimen only when clinically indicated. So the diagnosis is based upon a multitude of signs and symptoms, of which the basic panels I have elaborated in my earlier slide, but it is clearly seen that most of the studies which you can see have compared by using this bundle approach, the diamond shifts to the left, that is, it improves. So the multimodal approach of hand hygiene, healthcare, worker education, and feedback of catheter use can significantly reduce the COTI rates. So wherever we use the care bundles, it is important for the selection of the bundle because the bundle has to be concise, simple, and prescriptive. The elements of each bundle should be assessed properly. Actions are required whenever they're implemented during education and training. Then measurement and feedback is necessary, and the resources need to be checked because supplies or products should be appropriately procured to bundle rollout. The key messages are care levels, bundles, and reliable and consistent care systems. Simple 3 to 5 elements that are clear and concise should be adhered to, and they form the important part of the care bundle. It promotes multidisciplinary collaboration, consensus, and endorsement, and it helps to deliver the best possible care for patients undergoing treatments with inherited risks. Thank you very much.